Good day everybody. Here's a video on how to put a thumb spica cast. This is for educational purposes only and not intended for professional instruction or a substitute for expert help. It is important to consider that if you need thumb spica for yourself or someone else, do not attempt to apply it without proper medical training and materials. Instead, seek care from the emergency department or the ER, from an orthopedic clinic, an urgent care, or from a certified casting technician. As you can see in the video, we have already applied our stockinette. We are now applying our padding. In applying our padding, it is a must to consider that you need to do a uniform padding around the forearm and wrists. You need to avoid a sudden movement and make sure that the patient is in a proper alignment from checking time to time. Thumb spica cast is usually indicated for scaphoid fractures, thumb ulnar collateral ligament or the UCL injuries, decurvaneous tenosynovitis, first metacarpal fractures, navicular injuries or the distal rages involving the radial styloid. It can be from certain carpal bone fractures. Also, it can be used after a post ligament tendon repair, after those surgeries, from a thumb MCP ligaments or a tendon around the thumb. This will help maintain proper postoperative position. We are now done with our stockinette and padding. Starting on the proximal end, working our way to the distal part. We are now preparing the casting tape, which is a 2-inch 4 yards in size. We need to dip the cast in water, squeezing the extra waters. Again, working our way proximally doing a 50% overlap. Remember that a strong immobilization should be applied based on medical evaluation. This thumb spica cast is an example of it. Before applying this, you should have evaluated the patient medically, checked the imaging, and the diagnosis from a healthcare professional. As we are applying our first layer of cast tape material, making sure to have a 50% overlap, and checking that the patient is maintaining proper alignment and positioning our first layer is very important to mold the cast in the right position. Please also remember that it's contraindicated to a thumb spica cast, which is a strong immobilization, if the patient has a significant swelling that may worsen and a risk of compartment syndrome is inevitable. We are done with our first layer, and we are now making sure that the first layer is snugly fit and it's not over tight. We're doing some lamination to avoid the rough edges on the material. Again, contraindication for the thumb spica cast would be those with open wounds or infection under the cast. It is also not indicated if the patient has a poor circulation or neurological compromise. If there's a need for frequent wound checks, this is a big no-no. And lastly, we will not apply a thumb spica cast to an uncertain diagnosis requiring repeated examinations. A splint is preferred in these situations. As we are checking and folding the staccanet on the thicker edge of the base of the cast, making sure that those metacarpal phalanges, those knuckles, are freely moving and not being overly tight. From the cast first layer. In doing this cast, a high-level clinical overview must be done, starting with the assessment to confirm the need of a thumb spica cast. We need to check for neurovascular status, like the color, warmth, capillary refill, sensation, and pulse. Positioning is a high-level clinical overview as well. We have to make sure that the thumb is placed in a functional wine glass holding position or in a slight flexion of the MCP. It could also be a neural or neutral abduction, or the interphalangeal joint often left free unless injury requires immobilization. We are about to finish our second layer of the casting tape. After we have applied our stockinette from mid-forearm to past the thumb. The padding were placed uniformly around the forearm and wrist, and extra padding were added over the bony prominences. This would be your ulnar styloid and radial styloid. You also need to make sure that we wrap around the base and the web space carefully, avoiding any wrinkles that could compromise patient comfort and the positioning of the cast. We need to make sure that the cast is not tight nor constrictive in form. In molding and setting, we need to hold the position until the cast sets. Fiberglass usually takes just a few minutes. For the POP or the plaster of Paris, it takes more. Now we need to do our final checks. We have to reassess circulation, sensation, and movements of fingers, ensuring that patient can wiggle and expose fingers and the cast doesn't pinch.